From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews, and thank you so much for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at the Pagoda randomized clinical trial. This is a clinical trial evaluating continuous Ranibizumab via a port delivery system compared with monthly Ranibizumab in the treatment of diabetic macular edema. And joining me is the first author of the manuscript reporting the primary outcome for that clinical trial, Dr. Arshad Khanani. Dr. Khanani is the Director of Clinical Research with the Sierra Eye Associates in Reno, Nevada. Arshad, thank you so much for joining us.
Neil, thanks for having me today, and I'm looking forward to our conversation.
Great. Well, maybe we could just start with a brief explanation of this port delivery system. How do you describe that device, the drug delivery system, to your patients briefly?
Thanks, Neil. So, when I'm talking to my patients about the port delivery system, I let them know that, it is sustained delivery of anti-VEGF. And just like we have, sustained delivery of insulin via pumps versus insulin shots, it's a device that will continue to secrete drug in the eye, so that will make them avoid injections every month or every other month for their disease. Obviously, it's a surgical procedure, so many of these patients have questions about the recovery and what's involved with the surgery. And then we have to refill exchange the device in clinic at certain interval to replenish the drug in the device. So it's a very simple discussion about understanding that when we are treating a disease, if we have continuous delivery, we may be able to control disease better instead of peak and trough of drug with injections.
So let's talk about the clinical trial itself. I know you were evaluating both the efficacy and the safety of this port delivery system because we already have wonderful treatments in clinical trial results looking at anti-VEGF agents for treating diabetic macular edema. What was the efficacy endpoint you were looking for in this trial, and what exactly were you comparing?
That's a really good question. So, thanks to you and many others who have been pioneers in the field, we have excellent treatments available for our patients with DME. But you and I both know that getting these patients to come in and getting frequent injections, whether it's every month, every 2 months, even every 3 months, can get difficult. And especially in patients with DME, they have so many other comorbidities that it's very hard for them to keep their appointments. In addition to, most of these patients are working age, and frequent injections really are very difficult because they have to miss a day or two of work. So the efficacy endpoints basically was the fact that, we have excellent outcomes with intravitreal anti-VEGF injections. Can we control the disease as good as frequent injections while minimizing the treatment burden that is associated with those injections? Of course, in a clinical trial setting, we have to monitor patients closely, like every month, just to make sure that there are no safety events. But once a treatment is approved and it can go 6 months or 9 months between clinic visits, I think it's very, very relevant for this patient population. So the goal was, can continuous delivery get the similar outcomes as frequent gold standard injections? And in this case, ranibizumab, a 0.5 milligram, was used as a comparator given monthly.
So for similar outcomes, you were looking at the best corrected visual acuity from baseline out to about a year, or what was the time point of the outcome?
Correct. So when we are looking at, the primary outcomes, of course, it's about visual acuity, right? That's the endpoint the regulatory agencies use. And looking at the trial, we are looking at the average of baseline visual acuity over week 60 and 64. And the idea was that in this trial, patients did get run-in injections. So we wanted to count the visual acuity, almost a year after the run-in injections to see where we are heading with the port delivery system. Patients have surgery and then they have the refill exchange every 24 weeks. Remember, this study is still ongoing. We have presented the 2-year data. So I think the most important thing is obviously achieving the primary endpoint, which leads to regulatory approval. But from a clinician standpoint, we also want to know how do patients with poor delivery system do over time in terms of visual acuity, but more importantly, safety, because this is a surgical implant that's placed in the eye, and obviously the risk profile is different than what we have with injections.
I see. So there was a run-in period where all participants would be getting monthly ranibizumab injections and then randomly assigned to either the port delivery system or to continued monthly injections. Is that correct?
Yes, so they were randomized, and then the patients were randomized to the port delivery system. They received the 4.5 milligram ranibizumab injections. And of course, we know that the efficacy for the first 4 months is because of the injections that they are getting. And then the port delivery system was implanted for week 16. And of course, this study was also happening during COVID, so there were some delays in some of these implantations. So there could be a period for up to week 20 that they could be implanted. But beyond that, it was difficult, but was done because of COVID pandemic. Remember, this was actively recruiting during COVID, and many of the ORs were shut down. So there were some patients who received the port later on instead of that time frame of week 16 to 20.
Quite a challenge, and kudos to you and your co-investigators and all the staff for continuing this through that difficult pandemic time. So let me ask you, if you're looking at the visual acuity then, about a year after that implant was put in, how many times would the port delivery system be refilled? I presume it was filled once at the first time you put the delivery system into the eye, and then how many times afterwards until that primary outcome?
Only once, Neil. So its refill exchange was done every 24 weeks. So the implants were inserted between week 16 and 20 if they cannot get it at week 16. And then the refill exchange was done at week 40. So 24 weeks from the initial surgery, patients receive a refill exchange, which, as you know, is an in-clinic procedure that is very quick as long as you have experience with it based on, other studies and neovascular AMD approval that is already in place for this device. So yeah, only one refill exchange procedure was done. And then the primary endpoint, as I said, was the average visual acuity, week 60 and 64, and both arms showed comparable visual acuity gains.
And so what was the difference between them? Did they differ by a few letters? Did they differ by a line of vision? How close was the visual acuity at 1 year in the port delivery system compared with the monthly ranibizumab?
That's a really good question. So it was very, very close. 9.6 letters for port delivery system and 9.4 letters for the intravitreal 0.5 milligram ranibizumab injection. So essentially, the study met the primary endpoint of non-inferiority. That's why this trial was positive.
So that tiny difference, that 0.2 letter difference that you just told us about, the confidence intervals around that are probably very small, so that it was unlikely to be suggestive that one was inferior to the other.
That is correct. They were overlapping. So it was deemed non-inferior to the gold standard intravitreal ranibizumab. And as I said, this is a 0.5 milligram dose that was used in there because, in the US, we have 0.3 milligram approved, but globally it's 0.5 milligrams. So we wanted to make sure that we are comparing it to higher dose of ranibizumab to make sure that we are seeing comparable outcomes.
So not worse visual acuity, but also with continuous delivery compared with a monthly, let's say, bolus injection, not better either. Is that right?
That is correct. Yeah, it's not better. Initially, when you implant, you do see a decrease in visual acuity because the eye has to heal, but then that slowly comes back over time. So when you look at the BCVA curves in the paper, you will see that because patients are going through a surgical procedure, there is a decrease in visual acuity. It's not too much, but it's still, anywhere from 3 to 4 letters on average. So that's why I think patients need to be counseled that after the surgery, they may notice slightly decrease in visual acuity, which catches up over time.
Well, let's talk about that as we get into some of the challenges, knowing that the primary outcome of visual acuity was met in terms of being not worse in the port delivery system compared with the monthly ranibizumab. So tell me a little more about this potential change. Do many patients have this temporary transient loss of vision, or is it just a few of them?
I think, when you're looking at a large number of patients and you're looking at averages, I'm sure there is variability. We need to look at how many patients lost significant vision after surgery. But I can tell you, in my experience, of course, in the PDS group, we had 381 patients, so quite a bit of patients. In my experience, I enrolled over 20 patients in this trial. And I think it's variable in terms of how patients are seeing the chart. Even though the surgery is pretty similar. Some patients have more irritation post-op, as you and I know, versus others. There are some stitches in the eye, so some patients have a hard time, focusing or keeping their eyes open. So it's variable in my experience, but based on my experience, I know that this transient effect continues to improve very quickly within the next few weeks, mostly 1 to 2 months. Many of these patients are back to where they were, but I think it's just related to the surgical procedure and the eye being irritated post-op day one.
So they should be aware that on average for 1 to 2 months, they'll have this transient decline compared with if they were given the monthly injections, but at the potential benefit of not needing monthly ranibizumab thereafter. Is that right?
Yeah, that is correct. I think when I counsel my patients, I tell them that, you're going through a surgical procedure. It is something we do a lot of, at least in our practice, based on our clinical trial experience. But we know that sometimes it takes several weeks, up to 1 to 2 months even, for the vision to recover to baseline. It's nothing concerning. It's just a part of the healing process. And I say that in advance before the surgery. And I did not have a single patient complaining that, oh, my vision is down post-op, because they were already aware that this is something that's going to happen when we're going through a surgical procedure. Neil, I think the biggest value here is for the patients is the fact that, obviously this platform is now FDA approved recently, is the fact that once the eye heals and the eye is stable, then I think patients can go significant interval of time in between their clinic visits. Once this thing heals, then you don't even have to really come in very frequently once we figure out what that refill exchange interval is. And I had many patients, Neil, in this trial that had bilateral disease where they continue to get injections in the fellow eye. And these patients were asking, when can I get a port in my eye that I'm getting monthly injections? And recently an analysis was also presented at angiogenesis about fellow eye need and outcomes for patients in the Pagoda study. So I think these patients realized how this delivery system was benefiting them once it's healed. So I think the biggest thing is you want to make sure that the surgery is done properly and the post-op they're watched carefully, because as we will talk about, there are some complications that can happen that we need to keep an eye out for with the port delivery system. But with the learnings over the last decade, I think those risks are going down, but there are at least real risk with a surgical implant in your eye versus getting injections.
Well, let's talk about those potential complications other than that transient vision loss that you mentioned. What are the complications that the ophthalmologist and the patient will have to watch for if they've had this port delivery system? Can you tell me some of the more dangerous ones? Maybe we can start with endophthalmitis, but then go to changes in the conjunctiva that we should be aware of.
Yeah, that is a great question, Neil. I think the most important and I guess the most devastating event that patients can have, obviously, is endophthalmitis after a poor delivery system placement. And based on our learnings from the phase 2 ladder study, from the phase 3 archway study, and the portal extension study, is it's about the surgical technique and it's about the closure of the conjunctiva and tenons. So initially, when we were doing this, we were not really paying too much attention to conjunctiva and tenon because as vitreoretinal surgeons, we are more focused on the back of the eye and not the front of the eye. So this surgery is a unique surgery. It's not a difficult surgery, but you need to follow all the steps. So as you mentioned, how can a patient get an endophthalmitis after the placement of a port delivery system? Obviously, it can happen due to contamination during surgery, which is relatively rare, but the most common reason would be that the implant was not covered properly with conjunctiva and tenons, and there was a break in that, whether it was a conjunctival erosion that happened or there was a retraction of conjunctiva post-surgery that can lead to endophthalmitis. Now, if you get an endophthalmitis through the port delivery system, in a port delivery system patient, you can actually flush the port with antibiotics and do other things. But in this study, we did not see any endophthalmitis in the first year that we are, our paper covers. So that obviously is the most devastating thing that can happen, followed by conjunctival erosion or retraction. So if you are not dissecting the conjunctiva and tenons, you're not relaxing it, you have a very poor coverage of the port delivery system and the sutures are very tight and it's not overlapping at the limbus, what's going to happen is that the conjunctiva and tenons retract. And if you're not having overlapping conjunctiva and tenons, it will pull over and you'll end up with a retraction. And sometimes if tenons are not covering the port, you can end up with conjunctival erosion. So in this study, the risk of erosion or the rate of erosion was 1.9% with 6 patients, and the retraction rate was 1.3% with 4 patients. This looks much better than what we have seen in the past in the trials because there have been intense learning about optimizing the surgical technique. And one last thing is conjunctival bleb or conjunctival filtering bleb leak. So that was 7.8%. So that happens if the port delivery system is not sitting perfectly in the wound, and sometimes if the wound is a little bit larger than it should be, there is some leak. So you can see a bleb post-op. Based on my experience, most of those blebs resolve over time. Obviously, if you see a patient with a bleb leak and pressure is zero, it's a big concern, but I have not seen that because, obviously we want to make sure that we are paying special attention to the size of the wound. So those are the complications you can have. And the last one, obviously, is implant dislocation. So if the wound is, the scleral incision is too large, the whole implant can dislocate in the back of the eye. And that is something only happens if your wound is much longer or larger than what it should be. And there was one case that we had in this 1-year analysis, which was 0.3% of the patients.
So certainly we'll get more information, I think, looking at large insurance databases or registries as this gets used more and more in the clinical practice setting, and I think that'll be very helpful. Let's close with 2 last items here. I understand that the device, the port delivery system, had been voluntarily withdrawn by the company that supplies this. And can you tell us a little bit about that? And I understand that that's been resolved at this time so that it is once again commercially available. What was that all about?
That's a really good and relevant question. As you know, Neil, that it was FDA approved for neovascular AMD. And then 1 year or so after the launch, the company voluntarily recalled it because they were seeing something called septum dislodgement. So there's a septum that's present in the port delivery system where you are penetrating the port to do refill exchange procedures. And in the phase 3 trials, we noticed that septum dislodgement was increasing over time in the neovascular AMD trial, which had an extension study portal for another 5 years or so. As you said, it's important to get the long-term safety and efficacy data. And so it was recalled, and the company figured out that the septum had to be glued tighter so that it doesn't dislodge. And then the refill exchange needle was putting a lot of pressure on the septum. So they did a mild siliconization of that needle. And then in the lab, they went back and they looked at the old port with the old needle, old port with the new needle, and then the new port with the new needle. And what they can do is they can simulate 10 years of life or 20 years of life of the port by putting it in the lab. And what the simulation showed that with the new changes in the way the septum is in the port as well as the new needle, the septum dislocation in the lab was 0. And in the old port, the numbers were going up as more refill exchanges were done, just like what we saw in the real world where we were doing more refills and then more septums are being dislodged. So they got it back in the market. I have used the new needle numerous times, and that needle is very, very smooth compared to the old one. In the old needle, we had to put a good amount of pressure to penetrate the port, but here it's much smoother. So I think the problem obviously appears to be fixed, but at the same time, all of us have to be very vigilant and look to see if we are still getting any cases of the septum dislodgement with the new port and if we are having any issues with the new needle.
Well, that was very helpful. So finally, you mentioned that in the clinical trial, the participants were watched carefully every month, whether they were getting monthly ranibizumab or whether they had been given the port delivery system. Tell me a little bit more about how we might know when to see these patients in the clinical practice setting that are getting a port delivery system. When you're seeing them every month, you know when something's going awry, you know when maybe the edema is coming back in those few people where it shouldn't have been coming back, but it is. How often should patients be seen now in the clinical practice setting that have such a port delivery system, let's say in this diabetic macular edema setting?
That's an excellent question, Neil. And obviously, we have not used it in real world yet for DME. It just got recently approved. But I'll tell you, based on my experience in the Pagoda study, is that I think the first 3 months are super important to know what complications patients can get and how this disease will be controlled with the port delivery system. So in real world, as soon as it's available, when I start using it, I will obviously have a long discussion about risk and benefits to the patient, take the patient to the OR, see him the next day, see him a week after, and if everything looks good, see him, another month after. After that, I would like to see them monthly until proper surgical healing has been achieved, but also to look at their OCT to see how the macular edema is doing. Remember, it's a sustained delivery, so the effect is more on maintenance of anatomy instead of improving anatomy. So all these patients who are going to get this are going to have, run-in injections so that their disease is acutely controlled. After 3 months, I think I feel pretty comfortable that if I am not having a surgical complication, I probably won't have it. But I warn the patients that if they rub their eye or they notice extra redness or pain, they need to call us right away. So after the 3-month visit, I'll likely bring them another 3 months later, as long as the disease is controlled. If the disease is not controlled, you can think about giving a supplemental anti-VEGF injection as needed. But if I once figure out their schedule in terms of refill exchanges, like I have done for neovascular AMD, then I just bring them with that interval, whether it's 6 months, whether it's 9 months. So then we are decreasing not only just the treatment burden, but also the visit burden for our patients. But it does require more intense monitoring and visits initially compared to just giving intravitreal anti-VEGF injections.
Well, that's very helpful, and we really do look forward to continued follow-up on this trial and other trials looking at this, and also seeing what happens as this rolls out in the clinical practice setting. So thank you so much for joining us and sharing your insights and experience and expertise in this area.
Thank you, Neil. It was a pleasure speaking to you as always.
I'm Neil Bressler, and I've been speaking with Dr. Arshad Khanani on the primary outcome results from the Pagoda randomized clinical trial. This trial was evaluating continuous ranibizumab via a port delivery system compared with monthly ranibizumab in the treatment of diabetic macular edema. You can find a link to this article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network, and to follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for the JAMA Network wherever you get your podcasts. Thanks, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.